So good morning to you all. Welcome to Advances 2012, the 13th Annual Congress of the Trivandrum Abhijan Club. We start off with the day with a pre-Congress session on anovulation. We have specified that it is anovulation related to fertility, infertility. So we'll be touching mainly on the anovulation associated with infertility. And it gives me an immense pressure to welcome the faculty over here. We have the expert from Israel, Dr. Roy Homburg. Dr. Roy Homburg is an authority in ovulation. So I don't think there is any congress on ovulation without Dr. Roy participating. As he's come from Israel to share his experience to you. Welcome to this congress, Dr. Roy Homburg. We have the national faculty. Dr. Nalini Mahajan has already reached here. Dr. Mridu Bhashini from Kovai. Dr. Pradap Kumar is replacing Dr. Salim Daya, who was denied a visa to come over here in the last moment. The most important point of this workshop, this is the 5th workshop in the row. We spend almost 3/4 of the day focusing on a problem which is common to the gynecologists, to the infertility specialist and the reproductive medicine specialist also. So the most important thing is to involve yourself in the discussion, and we have kept a specific area for point-to-point discussion also, in which the audience will have to share their experience during that time. I am sure that you will all enjoy this 3-day academic feast and would take home not only points to ponder, but also enjoy the warm hospitality and the sweet memories of God's own country. Thank you, one and all.
Thank you, Dr. Jayakrishnan. We shall begin today's session on anovulatory infertility. The first talk being overview of anovulatory infertility, which will be covered by Dr. Jayakrishnan. Over to you, sir.
So, as I mentioned earlier, Dr. Salim Daya's talk has been replaced because of the last minute denial of the visa. And we have Dr. Pradap Kumar talking on metformin, and I'll be covering the overview of anovulatory infertility. The next 14 minutes or so, I'll be taking you on through the areas which the whole day session is going to focus at. Mind you, this is anovulatory infertility based on anovulation, and we are not covering any of the assisted reproductive technologies except for little bit of ovulation induction IUI. To know about anovulation, this is not the slides. This is not the slides. There's a confusion. Fair, it is written fair. I think before starting on anovulation, you have to know something on ovulation. Yeah, that's it. So I'll take you through an animated video of ovulation. It has got an audio. Can you just...
Ovary releases a ripe egg, or ovum.
Just a 2 minutes video before we
Inside the ovary are hundreds of thousands of follicles. Each follicle is a hollow ball of cells with an immature egg in the center. The typical 28-day menstrual cycle begins on the first day of menstrual bleeding. During the first 7 days of the cycle, a few follicles begin to grow at the same time. These maturing follicles secrete estrogen hormone into the bloodstream to prepare the lining of the uterus for pregnancy. Around day 7, all of the follicles stop growing and begin to degenerate, except for one. This dominant follicle continues to grow and nourishes the developing egg inside it. Around day 12, the follicle secretes a large amount of estrogen into the bloodstream. When the estrogen reaches the hypothalamus and the pituitary gland in the brain, the anterior or front part of the pituitary gland releases a huge surge of luteinizing hormone into the bloodstream. Around day 14, luteinizing hormone causes the follicle to undergo a sudden growth spurt. Right before ovulation, the egg detaches from the inside of the follicle. The bulging follicle releases chemicals, causing one of the two fallopian tubes to move in closer and surround the follicle. The follicle swells until it bursts open, ejecting the egg and fluid from the follicle into the abdominal cavity. In response, the fimbriae, tiny projections at the end of the fallopian tube, sweep across the ovulation site and pick up the egg. Microscopic cilia on the fimbriae surface transport the egg to the entrance of the fallopian tube. Inside the walls of the fallopian tube, muscular contractions gently push the egg towards the uterus. After ovulation, the egg lives for 12 to 24 hours, so it must be fertilized by a sperm from the male during this time for a woman to become pregnant. If it's not fertilized, the egg dissolves away and is shed along with the uterine lining during menstruation.
Coming to the epidemiology of ovulation, about 20% of the women experience abdominal bleeding to the lifetime. And most of the irregular bleeding occurs within 2 to 3 years after menarche. We all know that during the first year after menarche, about 85% of the cycles are anovulatory. And it is said that adolescents who have not established a 24 to 35 day cycle by 3 years after menarche has a 50% chance of a persistent irregular pattern. When you look at the LH pulses frequency before puberty, it ranges between 2 to 4, that is before puberty. After puberty, you find the LH pulse frequency, that is in 24 hours, increases from 2 to 4 to 6 to 18 in number, which initiates the cycle and ovulation and the subsequent changes after. When you look at anovulatory bleeding, it could be due to an immature hypothalamo-pituitary ovarian axis. This bleeding also may be related to sports participation, stress in the female, eating disorders, too much eating or under eating, and endocrine disorders like Cushing's syndrome. When you look at endocrine disorders related to anovulatory bleeding, it could be hypothyroidism or hyperthyroidism. Diabetes mellitus as well as Cushing syndrome is associated with anovulatory bleeding, and you have to investigate these disorders if you suspect them. Looking at the WHO classification of anovulatory infertility, to which the focus of our pre-congress session will be focusing on these four categories, the WHO classifies anovulatory infertility into hypogonadotrophic hypogonadism, which is grouped into group 1, which accounts for 10% of the cases, normogonadotrophic anovulation, which majority of it is polycystic ovarian disease, which belongs to the group 2 of WHO classification. The third group is hypergonadotrophic. Those are the premature ovarian failure group, which is group 3. And the fourth group is hyperprolactinemic anovulation. So today till noon, we will be covering all these 4 areas by various speakers and highlighting on the various issues related to it. As I told earlier, the WHO group 2, the polycystic ovarian disease constitutes the largest group in this. So 60 to 85% of the anovulatory disorders is constituted by PCOS. So we have to focus on polycystic ovarian disease because that is a major problem in our country also, and the patients in whom we deal in day-to-day practice. When you look at polycystic ovarian syndrome, it's not a disease. It affects 5 to 10% of the adolescents of women in reproductive age. And we find most of the time the women are overweight. Sometimes you find they are insulin resistant. They have acanthosis nigricans sometimes, hirsutism sometimes, and acne sometimes. The ultrasound criteria for diagnosing polycystic ovarian disease is more than 12 follicles, varying between 2 to 9 millimeters in at least one of the ovaries. And when you look at the ovarian volume, you find that the volume is increased more than 10 cc. And excluded are those on oral contraceptive pills. And if you find that the follicle is more than 10 millimeter, you have to exclude those follicles. The classical sign of chain of pearls is not required to diagnose polycystic ovarian disease. The typical picture which we get is a large volume ovary with more than 12 follicles varying between 4 to 10 millimeters, and you can find the stromal hyperplasia. You can note the increased vascularity of the stromal hyperplasia that shows that the androgen production is more. Looking at the insulin resistance, we find that 50% of the obese teens have insulin resistance. Lot of tests has been described, but insulin euglycemic clamp test is the gold standard which seldom anyone follows. We also find that 17% of normal weight women with PCOS has insulin resistance. So some people go for the checking of the insulin resistance, some people go directly for the insulin sensitizers in polycystic ovarian disease. To tell us more whether what is the current status of metformin, you have to wait for Dr. Pradap Kumar. Coming to the clinical signs of helping the lab investigations to help the other endocrine disorders, we find that 24-hour free cortisol is needed to diagnose Cushing syndrome. The IGF-1 is good enough to diagnose acromegaly. The DHEAS estimation is good to find out whether the adrenal is the cause of hirsutism. And if you look suspecting congenital adrenal hyperplasia, you have to look at 17-hydroxyprogesterone, and it has to be done in the follicular phase. So these are the investigations we extend when you suspect that you are dealing with Cushing syndrome, acromegaly, and congenital adrenal hyperplasia. We see a lot of women running in the early morning hours. This is lifestyle modification. So whenever you are obese, whenever you are hypertensive, or whether you are becoming diabetic, you start your lifestyle modification. The most important treatment for obesity, if you are obese, is diet. And thus there is some evidence in adults to show that low carbohydrate diet is much more sustainable than low fat. There are various diet regimes described. The famous Atkins regime, the high protein, low carb diet, and the Ornish diet. These are the various diets which you can prescribe and see whether it's effective. It is said that a high protein diet and the high fat are more appropriate for PCOS because it decreases the glycemic load, decreases the insulin, decreases the androgens, and you find that the patients fare better if there is an androgen excess. Looking at more diet, there is evidence that in adults that low carb diet is more sustainable than low fat. And if you are to do exercise, you have to shed about 2,400 calories per week. Bariatric surgery is kept as a last resort and is recommended only for morbid obese adolescents. Looking at this adolescent group of individuals, a large randomized trial of various diets and counseling has shown that there is no real difference in weight loss, about 6 kg at 6 months and 3 kg at 2 years. And whatever you do, you find that only calories count. And the best predictor of the success for diet loss will be attending a group session. If you attend a group like this, they share the ideas their beliefs, and that helps reduce the weight. Coming to therapy, clomiphene therapy is the treatment of choice in anovulation in appropriately selected cases, and up to 12 cycles of clomiphene citrate can be considered before switching over to gonadotrophins. Treatment with gonadotrophins, both HMG and FSH, is effective especially when clomiphene therapy fails and in women with low levels of estrogen such as hypopatients. And also in PCO, when they fail to respond to clomiphene therapy, the next drug available to us is gonadotrophins. Whether if you add GnRH agonist to gonadotrophins, is there any advantage? Particularly for ovulation induction, there is no advantage in routinely adding GnRH agonist with gonadotrophins, especially in clomiphene citrate PCOS. So GnRH agonist, yes, for IVF and ART techniques, but no for ovulation induction. What about insulin sensitizing agents? It is under a dark cloud now. It should not be used as a first line therapy. It may be beneficial in PCOS who are older and have an increased visceral obesity, and those patients who have failed to clomiphene citrate alone. Few words about laparoscopic ovarian drilling. When women with clomiphene resistant PCOS, you are given clomiphene citrate, you are given gonadotrophins, but still you find it is an unexplained infertility, there is an indication for laparoscopy. The surgical risk should be considered in these patients, and ovarian drilling should follow the standard protocol. The standard protocol being 4 to 6 punctures on 4 sides, 40 watts and 4 millimeter depth. The advantage of laparoscopic ovarian drilling over gonadotrophin therapy is it lowers the risk of multifetal gestation. So the risk of multifetal gestation is high on gonadotrophin when compared to this. This is aggressive puncturing. We find that people go for aggressive puncturing, tattooing of the ovaries, scarring of the ovaries, destroying the ovaries. And we have seen many of the patients coming to us with additions, premature ovarian failure. This has to be avoided. Not more than 4 punctures, or if you find the volume is high, you can go up to 6 or 7, but never destroy the ovary. This type of puncturing favors addition formation, and we have found a high risk of additions, ectopic pregnancy, premature ovarian failure in this type of aggressive punctures, and this should be kept in mind. In vitro fertilization is reserved when all the others measures fail, clomiphene citrate, gonadotrophin, your laparoscopy has failed. You have to take these patients for IVF. And to deal more with this, we have Dr. Roy Homburg talking to us on low dose FSH therapies. Aromatase inhibitors was there with us for a long time, was banned for a long time, came back for 2-3 years, again it has been banned. It has been found to be a wonderful drug, no doubt regarding that. It reduces the requirement of gonadotrophins. It has found to be useful especially in polycystic ovarian disease, to reduce the dose of gonadotrophins, and you find the associated complications. We find the difficulties of ovulation induction in absence of letrozole to us. Thank you, one and all.